Okay, welcome everyone. It's great to see you all. So my name's Dr. Irfan Ahmed, and I'm the MSK Playbook, the lead author of the MSK Playbook series, and we're invited you to this free launch webinar. We're excited to share with you the upcoming cohort 5 of the live course, and to launch that, we've given you a free webinar to update you to some of the materials. So today we're going to be talking about shoulder stuff. I'm joined by Dr. Imran Lasker, who's our MSK radiologist, and together, hopefully, we're going to make you more confident when looking at MRI imaging, be able to explain the scan to your patient and feel confident and excel at MSK imaging. So I'm a UK trained consultant in sport and exercise medicine, and about 4 years ago we started writing the MSK Playbook series to help you work up sports medicine patients more effectively in clinic, know when to get imaging, know how to explain the scan to your patient, and get to a stage where you could use that scan as part of your clinical workup and building rapport with the patient. Throughout the course, you'll get access to these infographics, these quick cheat code infographics that will help you to summarize how to work up a condition. And if you ever want to go back, you can always go back and revise and check them. I'm joined by Dr. Imran Lasker, who's an MSK radiologist, and he's designed some really cool MSK tutorials. So he's designed the MSK MRI tutorials for MSK clinicians, and they're set at the level where you could start to learn to read MRI scans. Maybe you get a report on your desk. Maybe you want to understand more about this and what it looks like on imaging. And today we're going to go through a shoulder MRI scan. I want to say a big thanks to everyone who supported this series. And I checked this out yesterday. Across the 17 or 18 blogs, we've now had 126,000 reads. And we're joined by webinar attendees from 39 different countries today. So it's fantastic to see the feedback. Do drop us a message in the comments and tell us, what condition would you like us to see cover next? What sports injury would you like us to cover in the next topic? And we look forward to meeting you all soon. So look, this is the scenario. You work in a busy MSK clinic and all these reports start dropping in your inbox. You've got a busy clinic and perhaps maybe you're just getting to grips with MRI and ultrasound, and you're looking for a course that's going to help you understand imaging better, how to use imaging in clinic, and how to improve the patient's experience. And every year on year, there's just more and more imaging, and it just keeps building up in your inbox. So this course and today's webinar is, I guess, the course I wish I had when I was learning. So when you start to learn from courses. So I went on a sports medicine course. There was loads of really cool information over 4 days. Then went on to do an MRI course for radiology fellows, which was pretty cool. But there was just like loads of radiology. And I thought, you know what, this is probably more complicated than I need to know. And what I really want to know is, how can I read the scan? How can I show the patient the key images? And how to explain it more effectively? Then went on an ultrasound course to learn interventional pain blocks, ultrasound injections. And for those of you who are interested in ultrasound, we now have an ultrasound face-to-face teaching course as well. I did further courses in ultrasound to try and build up my experience. Countless hours in NDTs trying to figure out what's going on. What does that report mean? I've got this long MRI in front of me. How am I going to explain this to the patient? And hours on YouTube just trying to work my way around different MRI tutorials. But really, you need feedback, and it's really cool that we've designed this course to help assist you. So that was my journey when I was training, and this is the course I wish I had, because that was like 12 days of teaching, over £3,500 of courses. And we've designed the MSK Playbook course, so in 2 days you can cover the basics of MRI, ultrasound, MSK imaging, and be able to use that as part of your clinical assessment alongside the popular MSK Playbook evidence updates. So instead of 12 talk days, we're going to teach you this in 2 days, and you get on-demand access. So you can always run it back if you ever want to consolidate your knowledge. So I'm really passionate about the course, but this is a feedback from one of our attendees from cohort 5. And we try and make this as interactive as possible and as fun as possible as you go through the course. So this will really stick. So when you look at these MRI scans and reports, you'll be able to pick up the key pathology and be able to take this back to your clinic. Often you might go to a course and there might be lots of information. You think, what can I take away from this? But we've designed a really cool online platform. So whatever situation you're working in MSK medicine, sports medicine, rehabilitation, perhaps seeing patients independently, we even had oncologists and medical consultants attend. This is really going to add that extra dimension, particularly when you're working out patients in the sports medicine clinic. And hopefully we'll give you loads to take away, and we hope you can get as much as you can from the webinar today. So whether you're somebody on the left, so maybe you might get loads of these reports and you think, you know what, I want to get good at understanding these reports. I want to get good at explaining them. I want to get to a stage where I can tell my patient what's really going on and instill that confidence in them. We've also designed it so you can do it the other way around. So maybe you're seeing the images now, so you feel confident with the reports and you want to get to grips with MRI and ultrasound, and you want to start to learn to interpret those images. And the way we've designed the platform, you have access to both. And so whenever you play it back on demand, you can always test yourself and really see how you're progressing. So I promise hopefully by the end of today, you can improve your confidence, learn to explain common scan findings. And today we're going to talk about shoulder, enhance your rapport with patients and improve that buy-in. And by the end of today, hopefully you're going to enjoy the course as well. For those of you who are interested in ultrasound training, we now have a face-to-face ultrasound course so you can scan this QR code and do register your interest. We've got a course running in the summer of this year, so we look forward to seeing as many of you as possible. Now, I'm going to hand over to Imran, and Imran has done a veteran of online MSK teaching. He's lectured on Radiopedia online, and he's designed some really cool MRI tutorials for MSK clinicians. And he promised me this every single time. No complicated physics. So Imran, I keep sending you patients, and I've got a really interesting patient. I think I popped the shoulder back in from this rugby player. Tell me what's going on. So I'm going to hand over to Imran, who's going to take over. So Imran is an MSK radiologist based in the UK, and he's got this really cool MRI tutorial. He's going to teach you about the shoulder. So over to Imran.
Okay, so thank you so much for that kind of introduction. Yes, my name is Dr. Lasker, Imran Lasker. I'm a consultant radiologist, and what we're going to do is work through a case together, work through a little bit of anatomy together. I promise it won't be too complicated, and then hopefully you moving on from this will be able to essentially look at a shoulder quite well and be able to explain it to your patients, or maybe even be able to diagnose problems that you get on the scan. Just before we move on, we are working Radiology Seminars on this. So Radiology Seminars is essentially the parent company of MSK Playbook, and we are on the NHS framework, which means that if you work for the NHS, then it's very easy to get approved to be able to come to the course and be able to benefit from it and use your study budget as well. So when you started the radiologist, that's me on the left over there, and you kind of write these reports for someone like Irfan, and he will read the report, and it's not always a great bit of communication because I will use words that he doesn't understand, and I will use words that he doesn't understand. You can't see my screen.
I can now. I
Oh,
can see.
sorry. Okay. Okay. Fine. So, yeah, he'll be using words that I can't understand, and vice versa. And so, this is the whole point of this playbook. We're trying to basically bridge that gap, right? So the communication kind of goes both ways, right? So I write a report, it goes to you, and you understand what all those fancy words mean, and I'll understand what you're asking for. And also on top of that, you'll be able to go through a scan with your patient who's sitting right there. So when you have a patient, they come in and they'll say to you, hey, I've had this MRI scan. They've said I've really busted something here, but I don't really understand the words. I haven't been able to get hold of the radiologist because they don't seem very sociable. Would you be able to have a look at the scan for me and explain to me what's going on? And when you open it, you're looking at it like it's the Matrix. There's all these numbers, and it just looks like a complete mess. You're not entirely sure what's happening. What we're trying to do is build that gap so that when you have a patient that's sitting with you, you're able to go that little bit further, way further than the other clinicians, the other physiotherapists, someone else who doesn't really have that much experience with imaging, and be able to increase your rapport that you have with your patients. So I'm sure, most of us here who are medical professionals have seen reports or had scans ourselves, and there's all this stuff that we write. All radiologists love to write stuff like this. T1, T2, stir, contrast, incidental findings, age-appropriate changes. I mean, where do you even go with that? Well, how do you even start to go with the patient and say, oh, okay, well, your stir sequences show this, your contrast images show this. What does it all mean? And this is what we're trying to decipher for you so that you're able to learn and take things forward. Now, for someone like me, obviously, I have done this as my job. I've been doing this for a very long time, almost a decade of learning radiology, and I've been teaching radiology for a long time. But for yourselves, it's difficult to find a good place to learn. You may go to YouTube, textbooks, you go to MDTs, you read some publications, which can be really boring. Some of your colleagues may have a little bit of like information, but know a little bit about imaging, and they may teach you. You go to radiology courses, which either not quite good enough, not really aimed towards someone like yourself, or you go to radiology courses where they're aimed at other radiologists and they get really, really complicated. And obviously there's AI, yes, of course, you may be able to put in an image onto AI and it may be able to point out some of the things. Well, what we found is that a didactic teaching is a really, really good way to learn, where we can go through cases together. I show you the anatomy, and then we go through the report and then go through the anatomy again and show you where the abnormalities are. And this is what this whole playbook is, why the playbook is so special, because you get access to all of that stuff moving forward so that you can actually help your patients and go through sort of interesting cases, example cases, be able to explain things properly. So key anatomy, I know it's going to be a whole big list of things, but these are the things are pretty much could be 99% of what you need to know. You don't need to know about too many other things beyond glenohumeral joints, acromioclavicular joints, the biceps tendon, the rotator cuff, and the subacromial space. If you know these things on an MRI scan, then you're pretty much most of the way there. Yes, of course, I know it can get more complicated with the quadrilateral spaces, the labrums, and all that kind of thing, and the suprascapular nerves, but that's not what you really need. That's going to be kind of quite subspecialist. Day in, day out, you're going to have these few problems. And as we go through this talk, we're going to go through some of the anatomy and all that kind of thing that can occur. So first off, what we're looking at here is an X-ray of the shoulder, and this is the left shoulder, right? So you can see the letter L there. So you kind of know where you are on this particular shoulder X-ray. So we're going to go through the anatomy on this X-ray, and then that will make things slightly easier for when we go through some of the cross-section imaging. And by cross-section imaging, I mean the MRI scan. So this little thing here that's sitting over here is this big circle, and that's called the coracoid process. If you know nothing else, this is the most anterior aspect of the shoulder. This is the thing that points forwards. And you actually have the humeral head that's sitting over here. That's the humerus. And you've got your humeral neck, and you've got your humeral shaft. And therefore, this must be the glenohumeral joint, because this over here is the glenoid. Glenohumeral means glenohumeral joint. Your acromioclavicular junction is sitting over here. And then over here, you've got your scapula that's going all the way like so. Now, when you're looking at X-rays, obviously you're looking for fractures. Fractures are going to be the big thing because you are looking at essentially representation of densities, and densities are represented really well when it comes to the bones. But the other thing you want to be aware of is the alignment, right? So that glenohumeral joint looks like it's aligned quite nicely. You've got your humeral head sitting over here, you've got your glenoid sitting over here, and that all looks very nice. But can we say that this person got dislocation and no dislocation at the moment? No, because this is a 2D X-ray, right? This is a 2D representation of a human being, and therefore you can't actually say that this is a non-dislocated study at this present time. You've got to have different views to be able to see. So there's two other views that may be useful. You've got your axial views, and you've also got your Y views. And actually, essentially, you only really need two views. You need your AP view or axial view, or one of the three. So over here, you can see that this. So you want to think to yourself, okay, so where were we again? So Imran said the most anterior aspect is going to be the coracoid process. So therefore, that's going to be the coracoid process because it's sticking really forward and anterior from the rest of the body. So therefore, this must be the anterior aspect. But over here, you can see the glenoid, and you can also see the humeral head. So you can see that it's a bit like a golf tee. So imagine if you had a golf ball sitting on a golf tee. That's essentially what you're looking at. The golf ball is sitting nicely on the golf tee. It's all aligned quite nicely. Therefore, this is not a dislocated shoulder. So this is all good news. We kind of got the anatomy slightly down. So yes, someone says we can stray away from the shoulder. If you mean by this can be dislocated, yes, it can be dislocated, and most usually it will be an anterior dislocation that can happen. The glenohumeral joint is essentially a ball and socket joint, kind of almost, but it's really held together welcome from Australia. It's really held together by a rotator cuff. Now, the rotator cuff are these tendons that kind of go around the humeral head to keep things in place. And the reason why we can move our shoulder so much is because it's not really encapsulating the shoulder like in a proper joint. It's a flat thing. So it means that your shoulder can go around. And what's giving it stability are the muscles and tendons around it. And that also means that there's going to be a propensity for dislocations. So Irfan's just messaged me and he says, oh, you know what, Imran, I've had this patient that had a dislocation, it got relocated. Do you mind having a look at the X-ray and tell me whether everything is okay? So let's have a look at this X-ray that Irfan sent across. And we try and think to ourselves, okay, so Imran was talking about whether the glenohumeral joint is adequately placed. Has it strayed away, like someone said here? So this is going to be the glenoid, okay? And we can see that the humeral head is sitting over here. So that looks like it's kind of overlapping with the glenoid. So this is all good so far. We think, okay, great. At the moment, it doesn't look like it's dislocated. It all looks like it's nicely aligned. And now let's go across to this way. This is the Y view this is the Y view that we were talking about. And it's a Y view because the scapula gives us letter Y. And what you want to see is that there should be some overlap of the humeral head with the middle of the Y, or at least it should be pointing towards it in this direction. So we can see here that this humeral head goes all the way around like so and overlaps like this. And you can see that that Y is sitting right in the middle there. So this is a not dislocated shoulder. So great. Are we going to move on? Is everything okay? Should we just sort of move on and say, actually, Irfan, your patient's completely fine. We've got nothing to worry about. Well, as a radiologist, I do need to look at other things. I do need to look at the ribs because I have to be aware that someone may have fallen over and hit their shoulder, but they could have broken a rib. They could have popped a lung. So those are the things that I need to be concerned about. But from a sports clinician's point of view, what's the other thing that can happen from an anterior dislocation? So when you have an anterior dislocation of the shoulder, the humeral head goes forwards like this, then it kind of tries to snap back into place but gets stuck. And then it might kind of scrape its way back and then go back again. So there's two areas where there's potential osseous or bone impact. So the impact can be here, which is the anterior inferior aspect of the glenoid, and it'll be the posterior superior aspect of the humeral head. So this area will essentially bump into here and then come all the way back. And when that happens, you can get indentation onto the superior lateral aspect of the humeral head, otherwise known as a Hill-Sachs defect. Now, the way I remember it is that the letter H is for humerus, and Hill-Sachs defect. So a Hill-Sachs defect points towards the humeral head. So the humeral head has got this little bit of a dent sitting here. Well, it's actually not a little dent, that's a massive dent. And so therefore you can tell that this person's had a previous dislocation. Now, why would Irfan be concerned about this patient? Because they've had the dislocation, but they've had a relocation. Now, the reason why Irfan might be concerned is because first off, they could have a rotator cuff injury. These tendons are all holding in place, may be very weak or torn as a result of the injury that may have happened. But also as a result of the impaction of this with this, you can have a fracture. If something's so significant it can fracture there, there's going to be some sort of injury that is located over here. So if you've got an injury that's located over here, that's going to be called a Bankart lesion. But there are two types of Bankart lesion that can happen. You can have a fibrocartilage Bankart lesion, or you can have an osseous Bankart lesion. So when I say osseous, I mean bone. You could get a fracture. So that's going to be an osseous or a bony Bankart. There's also like a fibrocartilaginous cap, like a suction cup that tries to hold things in place. And that can get injured too. And that's when you may want to go on to do an MRI scan to try and have a look and see what's going on with this person. So this is what's going on here. So this person's had a previous dislocation and what looks like they've had a remnant kind of reminder of what happened to them in the past, and therefore they will need to end up having to do further imaging, such as an MRI scan. So we were on number 36. So what we'll do now is if you come out and then go to the scrollable MRI case over here, and this is exactly how we do it on the MSK Playbook day that we do. You have access to scrollable images like you have here. We can go full screen, and what you can do is just kind of use your arrows on the keyboard. So go forwards and backwards like so. So what we can see here with this particular patient is that we have an MRI scan of a shoulder. And as you can see, we're scrolling through, we're scrolling through, we're scrolling through, we're scrolling through. And we're going to go through this a little bit more detail a little bit later. So what we can do is have a look at this X-ray and I mean this MRI scan and yeah, we'll have a look at the MRI scan and see what we think. So can you see anything grossly abnormal about this MRI scan? I'll probably need to go through basics first. So first off, this is called the axial view because we're looking from the top down onto the person, like we're light bulb shining down to the person. So we're looking from the very, very top. This is going to be sort of looking from them sort of straight on. So that's going to be the coronal view. And we're going to go through that a little bit later. And this is called the sagittal view. So we're looking from the side and into the shoulder like so. So when we are scrolling from this side, so let's go right to the very, very beginning. We're going to keep our eye on this area over here. Now, the humeral head should be a nice circle all the way around. But do you remember the X-ray that we saw earlier? We saw a little dent on the superior lateral aspect of the humeral head. You can see that dent sitting over here, like a really big dent that's sitting over there. So that's not great. And then we also thought, okay, so if they had an anterior inferior dislocation, that what will happen here is that this would go forwards like this, impact here, and then come back again. So now we've got to try and pay attention to this area over here on all the views. So scrolling through, we're now at this sort of anterior inferior aspect of the glenoid, and we can see that that looks like bone, that looks like bone, but this looks all mushy. Can you see how that doesn't look quite the same? It should really be a nice sharp line going along like so. But this doesn't seem to be the case. So therefore, this must be a bony Bankart lesion. The bone is gone. And also, can you see the kind of cartilage cap that sits over there and a bit of a little cartilage cap like a suction cup sitting over there is there in this area over here. Sorry, let's come back here. You see that over here, But as you kind of come down, it completely disappears. So this person's got a significant injury. They've got a Hill-Sachs defect. They've got a bony Bankart lesion, which also means that the suction cup isn't as good as it could be, and therefore the patient may end up getting recurrent dislocations, which is why everyone's probably sent this patient to me to have a look at and have further imaging for. So let's go back to the. It's taking a bit of time to load up. So yeah, so then what you can do is what we'll do, we've gone through the imaging, but what you sometimes you'll have is the other way around. So you'll have an MRI, you'll have the MRI report. So your patient comes in and says to you, hi, Irfan, I've got this MRI report. Do you mind just having a look and seeing what it says and maybe just show me what's going on? So we'll read through it. The bicep tendon is located within the bicep groove. Subscapularis, supraspinatus, infraspinatus tendons are intact. You know, there's a lot of big words here. The large Hill-Sachs defect. Oh yeah, so Hill-Sachs, H for humerus, Hills. Okay, so that must be something to do with the humerus. Defect involving the anterior superior, the posterior superior lateral aspect of the humeral head, measuring 4 centimeters by 6 millimeters. Okay, Bankart lesion is identified involving the anterior inferior glenoid. Appearances are consistent with a previous dislocation. Okay, right. So at first, it feels like a whole load of big words. You think, oh, you know what? I have no idea what you're talking about. But now, when you go back, remembering H for humerus, H for Hill-Sachs defect, we can come back to this and try and identify the things that we're talking about. And again, yeah, there you go. You do have a Hill-Sachs defect coming further down, right down to the anterior inferior aspect of the glenoid. You can see this kind of very abnormal area located over here. Therefore, this would be in keeping with the bony Bankart lesion. So the two ways that we do this is that for the beginning of the course, we'll go through the report first, and then we'll kind of pick the things that are kind of the most salient things. Okay, so they've mentioned, I don't know, supraspinatus tendon tear. They've mentioned this, they've mentioned that, and then we'll go through the cases, and eventually we'll be able to. Then after that, we'll be able to actually go through the cases first, and then try and sort of formulate some sort of report on our own, so we actually have sort of a blank canvas to work from. Right. So, any questions? So, yeah, oh yeah, welcome from India. Always a pleasure to have everyone from around the world here. So, let's go back to the talk. So, what we'll do now is go back to Irfan, who's then going to be talking to us a little bit about the kind of the evidence-based side of things, right? Is that correct, Irfan?
Do you want to go through the key views and
Oh, yes, sorry. Okay, fine. So we were talking about the axial views, the sagittal views, and the coronal views, right? And so this is the thing. So different views will show you things in a better way than other views. But the main thing is to understand that what each view is in the first place. And so when someone says to you, oh, well, what is axial view? What is sagittal view? And what is a coronal view? When you look at these images, what you'll see is that the scan will have 3 planes, right? And you'll have a line going through, and that will kind of just show you where you are on different parts of the scan. So, for example, you'll see that this line is over here, which therefore must mean that that aligns with this line over here. And so, therefore, you can kind of really pinpoint anatomy according to where you are. So, instead of seeing a 2D structure, you start to really build like a 3D structure of the patient. So this is what these look like, and I know it looks very complicated. Please don't worry. We're going to make things as easy as possible. But you've got your coronal plane, you've got your transverse plane, and then you've got your transverse plane, and then uh, you've got your sagittal plane. And I used to find this really difficult to try and understand when I was sort of studying the radiology, and sometimes the consultants, oh, look at the sagittal plane, look at the coronal plane, and I had no idea what they really meant. And so, from my understanding, I had to try and make things a little bit easier for me to understand moving forwards. So I started thinking to myself, okay, axial sounds like axe. So it feels a bit like when you've got someone that is going to chop someone's head off, that's what the axial view would look like. You're kind of chopping through the neck, right? So be a bit like this, it chops right through like a guillotine, and that's going to be your axial view. Yeah. And then when you get sagittal view, I don't know if anyone saw this film, but it's got American Psycho, and I think it's a horrendous part where I think he creeps up behind him and then he just slices him right down the head. So the guy's looking forward and he comes back, slices him that way. That's your sagittal view. If you get confused with what sagittal means, it's a bit like that sagittal helmet that those Romans used to have back in the day. It's kind of from side to side. So that's your sagittal view. Then you've got your coronal view, not coronavirus, but I always think about crown. So if you were wearing a tiara, it'd be like this. And so therefore, we'd be slicing down the body like this, right? So coronal, axial, sagittal. Axial, you're cutting someone. Sagittal, sagittal helmet. Coronal for crown. And that's kind of a good way to try and remember things. Now, the key bits of anatomy that we were talking about earlier, and pretty much, or I would say almost 99% of your problems that are going to come up in your clinics is going to be to do with these bits of anatomy, right? It's going to be your supraspinatus. Supra means super, so above. Infra means infraspinatus, inferior, below. And you've got subscapularis, so sub like a submarine, sub to the scapula, so subscapularis kind of goes beneath. And then you've got your glenoid, which is what we were talking about earlier, where you get these fractures and all that kind of thing. Now, this over here is your side view. You're going from the side. So it's like the Roman helmet, sagittal view. So we're looking at this patient from the side and we can see the muscle bulk that's sitting here, muscle bulk that's sitting here, and the muscle bulk that's sitting here. But as you start coming outwards towards the outside of the body, these muscles have got these tendons that are sitting right in the middle. And it becomes musculo-tendinous junction and then just becomes tendon. And the thing is, it took me a long time to understand this, but the tendons are like sheets. They're not really like tiny little ropes that go down. They're like sheets of paper or sheets of like a quilt or something that goes all the way along and then attaches. And they kind of attach like finger-like projections into the humeral head. So as you kind of come further out, you start to see that these look like sheets of paper like that, like that, like that. And so once you know what's the most anterior structure, which is going to be the coracoid process, therefore it's going to be the subscapularis. You can know, if you kind of go forward and backwards, you'll say, okay, this must be the subscap. That must be the supraspinatus that's sitting over here, and that must be the infraspinatus. Now, the way I have been describing, and Irfan apparently has been using with his patients, is try and imagine that this is actually like a little man. So his little eyes are there, he's got his little nose, and he's got his little happy face that's sitting over here. And he's got his hair. So he's got this sideburn, he's got his another sideburn over here, and he's got a little top hat over here. So when you're looking at someone who's got a rotator cuff tear, what you may find is that they're kind of thinning on top. So if they're thinning on top, they're kind of losing the hair, that's going to be like a partial thickness tear. And that can either be superiorly or inferiorly. So it can tear about here, it can tear around here. If it's around here, it's going to be your bursal surface. Around there, it's going to be articular surface because that's where your articular bone is. But then sometimes you have full thickness tear. So that means they've got lost all their hair over here and they've got only the sideburns. That means they've got a full thickness, full width supraspinatus tendon tear. They could have full width, full thickness subscapularis or full width, full thickness infraspinatus tendon tear. So you just got to look for that haircut and think, okay, how much of the hair is gone, which part of the hair is gone, and then try and infer that that must mean they've got a certain tendon that's torn. But also what you can have happen is that someone's got the clippers, have just gone right down like that. And so then therefore you'd have like a partial, like a not a full width, like a middle third full thickness tendon tear. Or sometimes you even just get a perforation. Someone's literally got a very thin clipper and just gone down. So once you kind of realize, oh, these are like 2D representations of 3D structures, I'm trying to think about that like a haircut style thing, it starts to make a bit of sense that when you're scrolling through, you start to see areas that are missing, and that will kind of tell you what kind of tear it is, full thickness, partial thickness, full width, and what surface, bursal surface or articular surface. And then that will start to make sense. And when next time you read a report, it will make more sense as to what part we're talking about. Now, the other area that's very important for people is going to be the biceps tendon, right? Long-headed biceps tendon is usually the one that gets torn for people as they get older. Normally, when you get proper bodybuilders, they'll get torn a little bit further down. But there's the long-headed biceps that's sitting right here, looking like a little fisheye looking at you like that. And that's very important to identify. Also to help you orientate, because you know that the bicep tendon is going to be very far anteriorly in the body. And again, we're looking from the top going down. We know that the glenoid is over here. We know the bicep tendon is over here. So anything over here is going to be the subscapularis. Over here is going to be infraspinatus. And this big muscle around the side is what big bodybuilders have, is big deltoid muscles. And I've genuinely seen people with big deltoid muscles and complete rotator cuff tears. And that's because they've been building up their deltoid muscles, and then as they got older, it kind of just rogers their rotator cuff, and most of the movement is coming from the actual deltoid muscle as well. So yeah, so this is where I'm talking about the case 5, which is the MRI case that we showed you earlier. And this is one of the cases that we had in our course. And this is what it looks like. So when you come in, you've got your cases, you've got your anatomy module where you go through these images and scroll through, and it gives you a good indication what the anatomy is, where it's labeled as you scroll through. Then you've got your case, then you got your report, then you got another case, then you got a report, case report, case report, case report. And this is really good because it means that once you finish the course, you can always come back, have a look at the report, try and read it and try and figure out, okay, can I go forwards? Can I go backwards? What can I learn from trying to learn on my own? And actually, when you go see patients, let's say they've got a supraspinatus tendon tear, you may remember, oh, actually, you know what? On the MSK Playbook, they had a really good example of one. So you can either go back to here or just go onto Google, type in example of supraspinatus tendon tear and go through the anatomy with the patient, because sometimes they don't have the images, but they've got a report and you have to try and explain it to the person that is there. Okay, so I think that'll be my bit done. I can hand over to Irfan, who will now talk about some of the more evidence-based things and the management things, because obviously I write the report, I tell you what's going on, and after that, I don't really want to have anything else to do with the patient. Only joking. I do care, but there's only so much I can do being a radiologist.
Great, thanks for that tutorial, Imran. And yeah, it's great to get MRI training, which is targeted just at MSK clinicians. So often we have trainees that come and join us in clinic. Maybe you might be an advanced practice physiotherapist and you want to learn MRI. This is an example of one of the key anatomy diagrams that you get access to. And as I still sometimes go back and reference these, they're fully labeled diagrams you can run through an MRI. And if you ever want to look at the key structures and test yourself, you can do. Throughout the course, you'll get access to 46 live cases with 46 reports, and we now have 10 bonus cases. So at the end of the course, we'll give you 10 MRIs, and we'll ask you to maybe do a mock report, and by then you'll feel comfortable reporting some of the common things you're going to see in a clinic. The good thing about this is, look, Imran does the MSK Radiology. I try to break it down in a nice, simple way. And how do I use MSK imaging in clinic? So this is one of my cheat codes lectures where I go through the key spaces like the acromioclavicular joint. If you were to measure these in clinic and maybe show a patient, what's the normal values and when could there be something going on and what type of injury should you be thinking about? So we try to bring it together in a way that makes it nice and easy for our trainees to learn, and particularly anybody who wants to get into sports medicine. We hope this is great value to you. We've had some really nice feedback from all of our readers. The additional bonuses, since radiology seminars has helped us out, we now have access to the on-demand course. So you do the course and you think, wow, that's a lot of information to take away. The course is now split up into videos, so you can access individual courses. Let's say you want to learn about frozen shoulder, steroid dosing, the volume to give an injection. You can go just straight back to that lecture and you can really consolidate your knowledge. So both those are split up into these small bite-sized videos. You can really just focus in what you want to learn. Just before I start, Imran, are there any more questions on the chat, or should we press ahead? Because I really want to know how to manage this patient. I'm going to go through some of the key evidence bits. Imran, is there any questions on the chat?
No question. Let's press ahead.
All right, let's go for it. Right. So look, now we know we've got a patient who's had a shoulder dislocation, and often, you know, you've relocated the shoulder, you've done the acute management, and you've got these kind of terms that come up in the clinic. And often the patient, you know, there's more and more MRI scanners out there. Patients are going out there, they're arranging their own scans. They're coming to you at clinic with a scan, and there might be phrases on there, and they want to know Bankart lesion, Hill sacks, muscle edema and fatty atrophy, denervation injuries, labral tears, and really they want to know, look, how can I simplify this? How can I take the noise away? How can I make this nice and simple so I can explain this to my patient? And I promise you by the end of the module and the course, you'll be able to say, look, I've got your report here. We're going to show you a couple of images from the actual scan. But actually, when I looked at your scan and your report and how you're examining, you've got a very typical pattern of injury with a shoulder dislocation. And I'm going to show you the scan and hopefully help you stabilize the shoulder. And if we need to do anything else, we're going to discuss this. But we've got a plan here. We've got the images and we're going to go through it. So the key thing about the course is we build up some of the evidence updates and bring in some of the latest papers. So, you know, you've got knowledge about what treatment options there. So first time dislocators, this is that patient that's got that Hill sacks lesion. We put the shoulder back in, but there seems to be a defect, and we need to know what that means for the patient, particularly if they're a sporting individual. They're a young athlete or patient who's going to push that shoulder. How stable is that shoulder going to be? And by far, the most common you're going to see is an anterior dislocation. But after you've done your early immobilization, and after they've been referred to the sports medicine clinic, what is it? What is it that you're going to take it to the next level to be able to assess them? This is an interesting review paper. We looked at a Cochrane review, which looked at 7 trials, and they looked at a kind of rehab options, and they looked at 704 patients. And people always have this, you know, do I put them in internal rotation? Do I put them in external rotation? How long do I keep them immobilized? And interestingly, they found there's no difference between immobilization and internal or external rotation for both redislocation or subluxation risk. So that's interesting, okay? So the jury's still out on this one, but certainly there's going to be an early period of immobilization before getting them moving relatively early on afterwards. So shoulder MRI made easy. You need to be able to reproduce this view in clinic. And we go through this with the trainees to bring that parasagittal view where we can look at the glenoid, and we want to make sure that the glenoid's intact and it's nice and healthy and there's nothing missing, no chunks taken out of it. And really importantly for the sports medicine clinic, we need to know what the health of the rotator cuff is. So we need to be able to convince ourselves that we can see the rotator cuff and it's tacked and there's no significant injuries. And on the course, me and Imran always have this backwards and forwards. I love T1 scans because it tells me a lot about alignment. It tells me about fatty atrophy in the muscle, stuff that really is important as part of your rehab alongside the fluid sensitive sequences. But we'll go through that on the course. So this is an MRI, okay? The MRI has been given to you, and the question is this shoulder stable post dislocation? To be or not to be? Is it stable? That is the question. And these are kind of your cheat codes for how you're going to get there, okay? This is what you're going to apply in clinic, and hopefully it's going to make your life a lot more easier. So you might have been in an MDT and somebody's been reading a report and they talk about this is on track or this defect is off track. And what do they actually mean? I mean, like on track, off track, on track, off track. It doesn't quite sound quite right when you're talking about a ball and a socket and the shoulder. So let's break it down. Let's make this nice and simple, because this is a concept that if you learn it and you'll be able to present this in MDTs and understand it, you'll better understand how to address shoulder instability. So the actual concept of on track and off track, we'll try and make it nice and easy. We'll take something complex from the report and make it nice and easy for you to understand. So it came from a cadaveric study back in 2007. And basically, if you imagine at the top of the image, we've got the humeral head, we've got the humeral shaft. And if you imagine the glenoid is here and they need to be contacting each other, there needs to be a contact area, okay? And I've made it nice and simple and I've put the glenoid as flat, but we know it's a little bit curved. But essentially, there needs to be an area where they're in contact with each other. So if you think about that track, what do they mean by that track? The track actually means that there is a space where the glenoid is touching or articulating with the humerus, okay? And if we take the contrast down, you can see that track there, you can see that track there, and it kind of makes sense, okay? So as the shoulder rotates, there needs to be a contact area between the ball and the socket. So let's run it forward. Let's see what happens. So it's really important because if you read this in a report, a Hill-Sachs lesion can help you predict the risk of dislocation, particularly in your patient. So this study of 29 studies looking at over 4,500 shoulders in a 2-year follow-up, you can think like all the predictable risk factors, being in a contact sport, overhead sports, increased dislocation risk, being of male gender, being on the dominant side, all increased dislocation risks, and just having a Hill-Sachs lesion increased the relative risk by 1.77. And actually, if it was an off-track lesion, it was even higher at 3.2. And losing the glenoid, losing the socket, it's not good for stability, and that increased dislocation risk. So they're talking about on track, they're talking about off track. What does that actually mean, and how does it actually look like? So let's take it forward. So if you imagine, look, it sounds complex, but we're gonna make it nice and easy with some diagrams here. So we've got the humeral head, we've got the glenoid, we've got the capsule around it. So we know the glenoid track, and we said that Imran was going to show us that on the parasagittal view, we kind of draw this line across and see how far it is. And then we need to figure out how wide it is. Without going into complicated physics, it's not exactly 100% of the width, it's 83% because it's a little bit curved and it's not exactly flat. But if we just take it for given that it's 83% of the whole width, then you can estimate that in various different ways. So it sounds complex, but let's make it easy. So we've got the humeral head, we're kind of moving the shoulder backwards, forwards, backwards, forwards, backwards, forwards. So if you've got no ball or socket defect, there's generally no instability, okay, unless you've got some other laxity or some other injury. So go backwards and forwards, backwards and forwards. This is a happy shoulder, okay? We can convince ourselves this is going to be a good athlete that's going to have good potential because they've got no defect. But what if I took a piece of the ball out? What if I created a Hill-Sachs lesion? And what if it was kind of in that contact area or that track that we spoke about earlier on? So let's run it back. So look, got the ball of the shoulder. It can still articulate with the glenoid, and we can convince ourselves that space in the middle, there's a little bit of a defect, but it seems to be covered on both sides. If we rock and roll it, rock and roll it, rock and roll it, backwards and forwards, although there is a defect, the shoulder does feel or seem relatively stable, and there are different measurements in how much Hill-Sachs lesion you can have, or it feels unstable. If you've got a small lesion and it's on track, generally that's better for the shoulder, okay? And then people talk about less than 25% bone loss, and there are various measures that you can go through, and we'll go through that on the course. But essentially, this shoulder can still articulate with the glenoid, so the humeral head is still pretty stable, okay? And the capsule is not going to get injured because there's plenty of coverage on either side of this defect here. So let's run it forwards. But what if we made this defect even bigger? Let's play devil's advocate. Let's make it even bigger. Okay, let's see what happens. Maybe we have a really big defect here. So now look, if we had to take this defect, you can see it's significantly bigger And actually, if we measure it, if we put that track back on, remember, let's take the contrast down. Okay, so look, that defect is kind of going over the edge of the track. So it's bigger or it's wider than the track. And actually, if we go further, we might have a problem here, because now we're going to measure the glenoid track. And if we took that width and superimposed it over the kind of glenoid that we would see, so if you imagine the ball's rocking, but the defect is bigger than the thing it's sitting on. Okay, people talk about like an ice cream scoop on an ice cream cart, maybe a golf ball on a golf tee, whatever analogy you use. This does not look stable. So let's run it forwards and backwards, run it forwards and backwards. So they start doing their rehab, but oh no, they're at risk. And this patient doesn't feel like they're stable. They feel subluxation. You're trying to rehab them. You're not progressing, and you can get engagement. And here you can see the Hill-Sachs has engaged with the glenoid, and it's caused disruption to the capsule. And this is what your patient's going to come to you and ask about. What's my redislocation risk? What does that mean for my shoulder joint health? What does that mean for my sporting career or my participation in sport? So the defect is larger than the glenoid track, and now that's a problem. Okay, that can increase the risk of dislocation. So we took something that's really, really complicated and tried to make it nice and simple. So this is more of an unstable shoulder. The previous example on track was more stable. So it gets even worse. Like, imagine if you took a piece out of both the ball and the socket. So remember Imran said like the glenoid falls down, it hits, so the humeral head falls down, it hits the glenoid and takes a chunk. Now we've got a chunk out of the glenoid as well. So this is now measured, and we do that kind of circle. But if we see here, the glenoid track is much, much smaller. If we measure end to end or the width, it's much, much less. And we've now got a big defect from the Hill-Sachs. So let's rock and roll it. Let's see what happens. So in order to measure this, you can use MRI, but people generally tend to go to 3D reconstruction, and you'll probably hear about in your MDTs, people talk about this concept. So kind of draw this ball or this best fit ball. There are a few different other methods, but they're trying to basically look at how much of that glenoid is intact, how much of the circle is still there. And as you can see here, it doesn't look like on the left-hand side, there's a full circle. So you're trying to measure like what a perfect circle would look like. And then you kind of superimpose, okay, I've lost that bit on the left-hand side. So I've got to kind of subtract that, and that gives you my glenoid track. Now, there are some studies, there's some really interesting studies, and you might hear about this in MDTs and people talk about it in the sports medicine clinic. But this is an interesting cadaveric study, and they showed that if there's more than a 15% of glenoid bone loss, then there's an increased risk of anterior translation of the humerus. So the ball is no longer sitting firmly in the socket. And think about how that's going to affect the biomechanics of your athlete, particularly if they're an overhead athlete, repetitive throwing motions, or particularly if they're lifting in overhead positions. Think about the forces at that ball and socket, and think about how stable that might be. And that's really important if you work in a rehab setting, or if you're working with patients post-dislocation. You're going to want to know a bit about this, and being aware of these key numbers and how to break it down from the report is really, really important. Now, one word of caution, how much loss of glenoid is significant? There is a little bit of variation, and people use different types of methods for this. And this is a study that showed that there's huge variability between the different ways that people use to measure it. So take it with a pinch of salt, but definitely you want to know how much of that socket's intact, because it will definitely affect the stability. So let's bring those diagrams back. Let's run it back. So we've got definitely less to play with. This doesn't look like a stable shoulder. We've now got what's called a bipolar lesion. So a bit of the Hill-Sachs is missing, a bit of the glenoid is missing. We've got a Bankart lesion. This does not look stable, okay? And then again, you've got this engagement, and you're going to have damage to the capsule. So quite potentially we need to build up that glenoid, or maybe need to fill in that defect in the Hill-Sachs. And that's really how you might go about explaining it to your patient on those more sort of high-risk patients. So bipolar lesions at higher risk of redislocation. So you can see from a report, it can often be quite confusing. These are kind of abstract concepts. We'll try and make it nice and simple for you to take away. Now, for those of you who come on the course, you'll get access to these infographics as you go along. We've got one for each of the major conditions. And as you're in clinic, if you forget everything, just go back to this infographic. So you're going to ask about the severity. So how many dislocations have they had? Was it kind of a low or high mechanism of injury? Could I explain why they dislocated? What's their Baton score? Are they kind of a hypermobile patient with wobbly joints? Get a feel for the other joints and assess their mobility scores. What level of sport are they engaging in? What's their training and occupation demands? Imaging, we're going to go for a plain film. Interestingly, the study is showing that point-of-care ultrasound is very sensitive and specific for picking up dislocations. If you're in the field of play or you're in a sports hall and you've got ultrasound, it's really cool because you can pick up dislocations really, really nicely. And then start to think about the Hill-Sachs defect. What percentage is it? What glenoid bone loss are we? And is there any associated soft tissue injury? Remember, Imran showed us that sagittal view. You want to bring in that person with a haircut and really interrogate the rotator cuff. You're now familiar with on track and off track, yeah? That this is no longer a mystery. You know exactly how to deal with on track and off track lesions, and you'll know a bit about what the report says, and you get to a stage where you might even be able to draw a best line of fit and start to work this out yourself. And then think about those other features that are really important: nerve injuries, red flag features. And we have a whole module identifying red flag features. And think about that fatty atrophy or denervation injuries if there's a neurovascular compromise. So if you ever get stuck, we've developed these for our advanced practice physiotherapists and sports medicine doctors in training, so they can always refer back to it and really go back and hone in. So we've got a heel sacs defect here. It's in the posterior superior aspect. There's no significant edema or effusion, so this looks like it's a chronic injury, but it does look quite unstable. The cuff tendons look intact on this parasagittal view, and actually this looks like an off-track lesion. It's got a high heel sacs, a bipolar lesion, and this patient's at higher risk of future redislocation. So we really need to think about our options of how we can stabilize the patient. So you can take a report, make it nice and simple, and be able to explain it to your patient. So if you do want to, we'll make this available for you free. So please do go on to the free stuff module. You can access the lecture slides and the case, which you can scroll backwards and forwards, as well as the report, and really test yourself. Go through it again and see how you do. So these are your cheat codes to take away in clinic. So Imran, we know on track and off track, and we know how to break down the report. We've got our key views module, which we've now added to the MSK Playbook Live course. We've had a number of interests for people who want to do the course, and they say, look, I really like the course, but I'd love to do it in modules. So Imran, you've got a course that's just right for them. So I'll hand over to you, okay? It's been great seeing you all, and please do keep dropping your messages and what conditions you'd like us to cover next.
We did have a question. Can we fix shoulder dislocations without surgery? If yes, there any chance to be re-dislocated again? So I can quickly answer that from a radiology point of view and from my time working at A&E and all the rest of it. Yeah, you can fix a dislocated shoulder without surgery. There's a maneuver, you kind of push it back into place. The problem is what we were talking about earlier with heel sacs defects and Bankart lesions and labral injuries and rotator cuff injuries. Occasionally, from the dislocation, you get injuries to some of the soft tissue or some of the hard tissue. When that happens, you get the situation where the person keeps dislocating their shoulder, and you may need to think about doing surgery. And so, with that patient that I showed you with the broken Bankart lesion, they have now got an area where it's not the head of the humerus is not being held in place. And if that's the case, it kind of slips, and they'll have redislocations and redislocations. And so, you'd hope once it's relocated, you don't have more dislocations. But unfortunately, people who've dislocated the shoulder once, they're more likely to dislocate again. And that's because of the other injuries that are associated with the initial injury of the dislocated shoulder. So I hope that answers that question for you. Thank you for asking that. Okay, good. So we are talking about modules. And so what we found is that it's not a one size fits all. And therefore, as the MSK Playbook is really on a mission to try and change the way that we are interacting with our patients, I'm helping you to help me and vice versa to try and make things better for our patients. Some institutions would rather go for a more modular course or a modular approach. So we have got a session dedicated to the shoulder and the upper limb, because sometimes you have people who very much specialize in only the upper limb and they only really want to know as much about that as possible and not so much about the knee and the elbows and the rest of it. And you've also got a lower limb module as well for those of you that really subspecialize in looking after knees and the hips and that kind of thing. And what we've done is really break down a lot of the stuff that we've got from the main course, where we kind of do go through everything and really deliver it in specific sessions. And so some institutions would prefer to have weekly sessions on a Wednesday afternoon, for example, where they've got everyone together logging in online, and they want to really hammer home very specific topics, and that can be very, very useful for some institutions. So if that's something that you'd be interested in, then do get in contact with us, and then we can try and organize something like that for you. Now, the MSK Playbook itself, which is the course that we've been talking about, where we do go through quite a lot of information, is a essentially 2-day course. It's all delivered online, and you do get on-demand access, and you can also get access to a lot of the material afterwards. This is just some of the stuff that we go through. If you're interested, please do check out the website, do have a look. And I think genuinely everyone that's been on it has found it very, very useful for themselves and their patients, and been able to increase their own work and been able to really deliver very, very well for their patients. And so that they kind of come in and come in, and then they are able to sort of explain scans to patients. Also, the thing that we'd say is that what we can do as well, like we have like a Q&A session at the end where we are able to we can go through a scan that you have found. So you may have a patient that has given you a picture, or you've taken a photo, as long as it's anonymized, by the way, then we can go through that with you, talk about, how you'd actually go about explaining that to the patient. And common things are common, after a while, once you've seen one thing, you can explain it again and again. You said, can you cover next time the cervical impingements because they're very common in patients? So interesting you mentioned that. Part of the MSK playbook is we also go through lumbar spines, and part of the lumbar spines we also go through some of the C spines. And what you find is that a lot of the pathology that happens in the lumbar spine will happen in the C spine and vice versa. So yeah, we do go through those kind of things because yes, we know that that is a very, very common thing to happen for patients. They get C spine problems, nerve issues, impingements, and all that kind of thing. And actually, I think it is day one where there's a humongous amount of time spent on the spine because it's such an important topic for us clinicians. So many patients come in with back pain, just so many. So yeah, that is something that we do. If you do want to have a look and maybe consider coming in to our course, do use a QR code. We do offer group discounts as well, so that if you do want to come together with people, maybe have a crew of you turn up, then yeah, have a chat to us. We can definitely work something out for you. As a bit of a prize for all you guys that have turned up for this particular webinar, we'll be sending out a 20% discount for you guys to register in the first 24 hours. So just go have a look to the website. It'll be 20% discount from the website link that I've given you. So do sign up if you want to. You do get a bonus 60-minute post-course session as well, where we'll go through some additional material, go through some real life cases. If you want to go through a case of your own, then we can do. Sometimes people will turn up with their own case. I could probably turn up with a shoulder MRI of my own from when I dislocated it all those years ago. And do sign up to our mailing list as well, because we are working on a lot of stuff, and it's actually by popular demand. It turns out a lot of people want to learn about ultrasound. I can completely understand why. Very, very good to have right there and then when you got a patient who's come in with pain, and then you might want to have a go at the ultrasound and try and help someone. So yeah, have a sign up. We are working on this ultrasound day course, and that's something that will be actually physically hands-on. We can do sort of an online version, but it doesn't work so well. Generally speaking, you want to do ultrasound hands-on, and that's something that we're working on. And then, yes, we also have on-demand access for people who turn up, and that's something relatively new. We've shown you a bit of the platform already where you can actually see that every single video is there, pre-recorded and ready for people to be able to go through as well. And also the cases will be there as well. So yeah, it's a really formidable course. Irfan have I been working, I mean, yeah, we've spent hours and hours working on this. We work from the feedback from people. We would like your feedback about this as well, by the way. If you thought this is a good webinar, then great. We really appreciate that. If you didn't think it's very good and you want something better, you think they didn't really communicate what we needed to, then do let us know. But the course itself has been well received so far. We've worked on the feedback that we've had so far, really concentrate on the aspects that people have talked about. So yeah, I hope you found that really useful. Do sign up. I can stick around for a few minutes just to get any questions and all that kind of thing. I'm going to leave the QR code for anyone that's going to be a keen bean and who just wants to sign up and just get going. I really, really hope I see as many of you there as possible. I'm just going to keep things open. So I've answered that question. I've answered that question as well. If we don't have any other questions, then I think we can close things off. So, Irfan, do you have any last minute things you want to say?
Yeah, so I just want to say massive thanks for everyone for joining us. I'll just take you to the website. So if you want to learn more, like let's say you enjoyed the webinar and you want to take this further, you can go ahead to our website and we have the upcoming cohort 5 of the MSK Playbook live course. And somebody asked about radicular pains or radiculopathies. You can access all of the course modules and schedule and advance here. So you can see that on day one of the course, we've got module 5.5, which is about sciatica, radicular pain.
Do you want to share your screen if you can? You sharing
Yeah,
your screen? Yeah.
I've just give me one second.
Yeah,
Can
got
now
it.
see your screen. So
Yeah.
if you want to go to the MSK Playbook course, we've got an upcoming MSK Playbook live course coming up on Monday, the 12th of May and Monday, the 19th of May. And you can sign up now, okay? When you sign up to the course, you get access to all the pre-course reading materials and you can have a look at all of the MSK Playbook blogs online, okay? The course module and schedule is included online. And as you can see here, it's pretty comprehensive and we go through all the common MSK injuries and sports medicine injuries that you are going to see in clinic. So do check us out and do check out that link from the top. You can also access and now pre-register if you go across the ultrasound training in person. You can maybe you work for an institution that is looking to develop ultrasound in practice or develop this in your clinic, and if you want us to come and invite us to come and teach you, do just register yourself, and we will be happy to come down and teach you about the use of point of care ultrasound in clinic. So we're going to stick around for a couple of minutes because I love meeting and hearing from the readers of the MSK Playbook series. Like I said, we had people from 39 different countries registered today, and I want to know, what topic do you want us to cover next? Because we've got a couple of topics that are still ongoing and they're about to come in the next couple of months. So what topic would you like us to cover next? Please put your messages in the chat. If you enjoyed the show, we would love if you maybe retweeted or posted on LinkedIn about maybe a blog that you read, because really your feedback is the oxygen that we need to keep going. And as Imran said, we've been doing this for about 3 or 4 years, and your feedback is how we keep making it better and better each time. Okay, so please drop your comments in the messages. So do join us for the upcoming live course on the 12th of May and the 19th of May, and we look forward to seeing you again soon. So I'm going to stop sharing my screen. Okay, Imran, any other questions in the chat?
They just said the word chondrocalcinosis. So I think that's going to be sort of a more degenerative rheumatoid sort of area. I think we touched very briefly on that, but it's not really a focus of the MSK playbook. We're really sort of dealing with
Imran,
Yeah, go on.
that is one of the modules from the MSK
Oh,
Playbook.
you've got one there, is it? Okay, fine.
Yeah, so you actually go to the pre-course reading list, and if you want to look up, maybe you see patients with tennis elbow, rotator cuff tears, frozen shoulder, inflammatory back pain. Day one is all about upper limb and spine, and you just click on the link here, and it will take you directly to the MSK Playbook blog, and you can learn all about chondrocalcinosis and more of the medical workup that we cover in the course. So who needs bloods, who needs further investigations, and when you might consider red flag findings and what to do with them. So if you ever do want to have a look at any of these conditions, you can always just go onto the website, and you'll get links to all of the blogs together. The meniscus one's pretty popular, and we've got bone stress injuries in day 2. I really like day 2 because we cover stress fractures and who needs bloods, as well as knee and hip problems. Very, very common in the sports medicine clinic. Good. Any other questions?
No other questions.
All right, great. So we've taken you up to an hour, and we thank you for your time. Your time is very, very precious, and we look forward to seeing you all soon at the upcoming MSK Playbook live course. Thank you so much for joining us. It's been a pleasure to be here with you today. So thanks for myself and Imran. See you all soon.